I was invited to give a talk on the relationship between brain atrophy and cognitive impairment. You know, cognitive impairment is observed in about 2/3 of people with MS, and up until recently it's been pretty much ignored by most neurologists and healthcare professionals, but not by the patients. So we've been doing a lot of work over the years looking at the relationship between impairment and degree of brain loss or atrophy, and how that relates to cognition. And that's the kind of work that we've been doing and presenting here today. I think that physicians over the years have been more looking at the physical aspects of the disease. I think that they also felt that there was more treatment for the physical aspects of the disease. But I can tell you, 20, 30 years ago, people in medical school were taught that cognitive problems were not a manifestation of the disease itself. So their understanding was there are no cognitive problems associated with disease. So that's changed in the last 20 years. Now it is imperative that people look at cognitive problems. Now it's not as big an issue as some of the motor and physical things or fatigue in MS. But people are starting to recognize that cognitive problems is a definite manifestation of the disease itself, and one of the most important aspects of the disease that results in poor quality of life, significantly associated with loss of employment and all kinds of activities in terms of family dynamics and such. So therefore it has to be assessed. It's much more abstract, of course, you know, and it's much more individualized. So for example, if you were a CEO of a major company, you might show some subtle signs might become very significant for you. If you were really not that, you know, if you were working in another field where it didn't demand a lot of cognitive effort, you may not see it until much later in the disease. It took 20 to 30 years for people to understand that cognition is important. Now people are saying, well, what do we do about it? There are no medications that are approved to improve cognition. We've been doing a number of studies at the Kessler Foundation on cognitive rehabilitation. And our studies have been showing that we can significantly improve learning and memory in persons who have problems. And so that's the scientific data. The problem is that scientific data is not yet getting into practice, certainly not in the United States. And that's the next big thing, that we need to be able to get clinics to refer to for cognitive rehab, but we also need to get insurance companies to pay for it. Otherwise, people are not going to get the treatment that they need. That is a huge effort, a huge effort. It's essentially public policy. I think there's a lot of issues that you have to do. The research we do can only support the effort. We can provide the data, the research to say cognitive rehabilitation works. But then it really becomes to the clinicians, to the insurance companies, to politicians to say our patients need this treatment to get better. Cognitive impairment is pretty much independent of physical disability. If you look at the time course over time, as people get worse on cognition, they'll also get worse in physical disability. However, you can have people who are newly diagnosed, have no physical problems, and have significant cognitive problems. So the relationship is not really that clear, and it can be the primary symptom. Age is a factor in that if you can actually get MS as a child, and as a child we know that the MS, the cognitive problems, can be pretty significant. And I just saw some work that was presented here that there is a significant brain atrophy in certain areas of the brain that may never even recover. On the other spectrum, people who are in the elderly, you have much more of a challenge in are the cognitive problems that you start to see in aging related to MS or sort of normal aging. That could be a bit problematic and difficult, and that's where you really need a sophisticated evaluation. You know, right now, MS is really governed by neurologists. And neurologists traditionally, most of them have been, like I say, pretty much focused on sort of the mobility, motor problems of the disease, fatigue, treating symptoms like sleep disorder. The neurologists are starting to understand that cognition is important. But there's no pharma industry for behavior. Okay, so the physicians will get a lot of background on the newest medications for reducing, relapses and such in MS. They hear nothing about the rehabilitation literature. This doesn't exist. So you leave it up to them to try to do that research, and it doesn't happen. They're too busy, and so it's going to take a lot longer than we would like. We need to be able to keep telling clinicians that cognition is critically important. We have to be able to do a proper assessment. We have to figure out exactly what the rehabilitation efforts might be. What are the efforts, for whom, at what dosage, what duration? Do you do an intervention for just a few weeks, or do you do it for the rest of their lives? How do we do these things? There's a lot of work to do. However, we have to start by saying people need treatment. Cognitive problems can affect a whole slew of everyday life activities. People focus on employment. 5 years after diagnosis, a majority of patients with MS can actually be unemployed. But it can also have an impact on daily functioning, household activities, interactions with family. The newest work that we're doing at the Kessler Foundation is we're looking at people who are having difficulty in recognizing the affect in another person. If a person with MS can't recognize the affect in another person's face and how they react, how does the MS patient understand how to respond to them? That leads to sort of difficulties in interpersonal relationships. And so that's really important, and that's brand new. I think, number one is you have to identify there's a problem. Most neurologists don't even know this is a problem. And number two, we've actually starting to develop some interventions for facial affect recognition difficulties. And so far, very preliminary work is very promising, but that's still a long way away.